So for this case, we have a 68-year-old male. He's got chest pain, diaphoresis, and this all happened while he was playing tennis. He's got a very low blood pressure, 80 on palpation. So because of this low blood pressure, it's pretty easy to say that he is in fact unstable. Now, when it comes to the rhythm strip that we're going to be utilizing to determine treatment, we're going to approach this in a bit of a stepwise fashion. We're going to consider a couple of criteria that will all point us in the direction of what, in fact, is going on with this electrocardiogram. So, first things first, we're going to start with trying to determine the rate. Right off the bat, you can see that this is a tachycardia. It looks fairly quick, but we want to be a little bit more accurate than that. So what we're going to do is take one of these R waves and compare it to a following R wave and see that relationship between a large big box to give us a more or less a good range as far as what the heart rate will actually be. Now, if you'll recall, if we have one R wave on one of these borders of these large boxes, if there was to be another R wave on that same border, the rate is going to be 300 times a minute. Because we have another R wave or R wave number two right here, a little bit after this big box, we know that the rate is less than 300, but it's definitely greater than 100. And we can even further deduce that the rate is between 300 and 150 times a minute. So for the purposes of this, just based off of the proximity of these intervals, I think it's safe to say that the heart rate is about 200 times a minute. From there, we're going to take a peek at what these intervals are doing. And this is important because it's going to give us some ideas as far as where this is occurring within the heart, as well as classifying this particular type of tachydysrhythmia. So as we look for our intervals, we're considering the P waves, the QRS complex, and the T waves, specifically the QT intervals, the distance between a Q wave and a T wave. Now, when you have rates that exceed 80 beats per minute, you're going to need to use the QT corrected formula. And so for the purposes of this uh, rhythm strip, the QT is going to be less of an issue, and we're not going to consider it as being as critical than some of the other intervals, such as the P interval and the PR interval in the QRS complex. So right off the bat, we can tell that the QRS complex is narrow, and it looks like it is well within the range of less than 120 milliseconds. And so we don't have a wide complex QRS. And if we're looking for P waves, we'll notice that we really kind of don't see any P waves preceding each QRS complex. They seem to be missing. And so that's helpful because that really does allow us to kind of formulate a differential diagnosis and more accurately get an idea of what we're actually dealing with. So when we have a regular, narrow tachycardia, there are only a few things that really cause these types of arrhythmias. And so we've got a flutter with 2-to-1 conduction. We have sinus tachycardia, and we have AV nodal reentry tachycardia. Now, when it comes to figuring out which one of these is going to be our rhythm that we see before you, we really got to take a couple of things in consideration. The first thing that we need to consider that really will enable us to get rid of one of these differentials is going to be the fact that we don't have any observable P waves, nor if there were P waves, that is, we don't really see them consistently preceding the QRS complex. So right away, we can knock off sinus tachycardia. That's not what this is. We also notice that the rate is incredibly fast. And so as you can see over here, the estimated rate is greater than, or rather approximately 200 times a minute just based off our RR interval, which means that this can't be atrial flutter because atrial flutter with 2-to-1 conduction has a pretty consistent rate of 150 times a minute plus or minus 15 beats, and 220 is far greater than 150. So we can X that one off too. Finally, we're left with AV nodal reentry tachycardia. And this is going to be the more logical diagnosis, not only because we've effectively eliminated sinus and A flutter with 2-to-1 conduction, but the rate is just too fast for it to be, really either of these two. Additionally, if we look at each individual R wave, we can tell that if we were to measure this one and this one, we would essentially have the same distance as far as R waves are concerned throughout the entire strip, and that is very, very specific for AV nodal reentry tachycardia. So, because this person is unstable and we are going to manage this dysrhythmia with electricity, ACLS generally recommends 50 joules starting with synchronized cardioversion. Obviously, you're going to add sedation. It's an uncomfortable procedure.